surgery with the patient with high myopia, retinal detachment, and macular hole. First, and I thinking that when the retinal detachment caused by macular hole, we peeling the integral limiting membrane is very difficult. But when we do it, but after I do it, I think is when peeling the internal limiting membrane in the patient with macular hole is even easier than is a patient with macular hole only. Why? Because we thinking that retinal detachment already detached. So already detached, so we not afraid about maybe we touch to retina, we make brain is retina and make the retina detachment again. So that when we do the surgery, when you peeling the ILM is more confident. And another one, if you already do the macular hole in the patient with high myopia, but the retinal still attached, not detachment, is very difficult. Dr. Cho, she already know that because in the patient with high myopia, all the central and the macula already degeneration by high myopia. And that means in this center of the macula is changing, very difficult to see the internal limiting membrane. So that means very difficult to peeling it. And so when the retinal already detached, so you can see easier. And often, if the patient with staphyloma, so very difficult. If still the retina still attached, because the color of the staphyloma is white, and even you can use coloring for the ILM, so it's very difficult to see, to peeling it. So that means this surgery is quite challenging for the doctor to do surgery. But by time when I do it, and I think it's the most key for the patient to do surgery for retinal detachment with macular hole, we have to peeling the internal limiting membrane for the key for successful for the patient. And some doctors, they thinking that they can do take the fluid under the retina by the macular hole. Some make retinotomy near the optic nerve in the retina. But in my experience, I often take out the fluid under the retina by through the macular hole is easy. Some doctors are thinking that it will make the macular holes bigger, but by my experience, is still not harm to the macular hole. But for my experience, I never use a laser on the rim of the macular hole, because I thinking that if you use a laser on the rim of macular hole, maybe it makes more atrophy in the rim of the macular hole. But some doctors, they can make the laser, but in my experience, I never do it. So any question or comment? Yes.
Yeah. I think you look
Tired from your impressive presentation. I think you choose maybe the patient complicated case, I think, with high myopia, retinal detachment, macular hole, and atrophy, staphyloma, something like that. It must be different with the idiopathic macular hole, and in that case, the strategy must be different. Your case in the treatment more complicated. Dr. Kung, maybe some words, not medical link, I think, before retina, that means pre-retina, not before retina, or after retina must be sub-retina or posterior retina. Yeah, it's the professional, I think, not academic or medical link, I think. And when in a surprise, you just show us the scale blocking, we push directly would present on the macular hole directly with the implant, I mean, but the PMMA implant scale blocking. Yeah. How much does this cost in Vietnam? I think I just talked with the professor. Yeah. We have not until now. We have not so far. We don't have that implant in Vietnam market, I think. And I think this is good initiative, instrument. Yes. And yeah, you know that in that high myopia over than 6 dioptry, usually combined with membrane, I think that neovascular membrane subretina. So how can you choose your patient without that membrane by OCT or by angiography, something like that?
About your first question, as I mentioned, now we have 3 materials to make macular buckle, including silicone, PMMA, and titanium. And the cost of PMMA approximate $400.
I'd like to ask you, when you use the macular buckle, and it will make will make to cause the macular deformation. So does the patient feel metamorphosis?
Yes,
Nhân có gì biến dạng không? Vì cái này nó làm cho cái biến dạng
cái này là cái phần mới mà em đọc ở trên ấy để đưa lên để ra vấn đề. Tôi think mình cũng chưa làm cái này bao giờ. Đọc để biết để xem chưa có vấn đề.
Recently, I researched on the NCBI. One doctor used macular buckle, and after 6 months, the retinal come anatomical success, and his visual acuity about 100.
Without glasses.
Without surgery, he just only used macular buckle.
Visual acuity, uncorrected visual acuity. With glasses?
Yes, sure. Without glasses, not some.
Without glasses.
I have a question for the person. I would like to ask about the prognosis for the surgery. Because when you do surgery and maybe the myopic pathology still remain, so the retina will progress degeneration. So it's recurrent after that, after surgery.
Oh, because the patient with high myopia. Patient with high myopia is still have a high myopia, have a retinal and choroidal degeneration. Still happen, and but even though the patient if he have a retinal detachment, we have to do surgery. And many patients, when I follow up in this situation, often the patient also maybe in the future they maybe have a choroidal neovascular membrane. So that means after we have to injection Arastin. So that is with high myopia is a very big problem. In my experience, when the patient with high myopia, we have to check in the peripheral of the retina. If there's any happen in the generation, we can use a laser for proliferation of retinal detachment for the patient. Because if the patient in high myopia, there's many complication after the patient can really happen in the future. So it's easy already happen. So you have to look up for the patient with any retinal brain and retinal degeneration. We have to treatment by laser for treatment any retinal tear for prevention of retinal detachment. Many patients maybe they have a macular hole. So if any macular hole for lamella macular hole is easier, so we can do surgery quicker. For successful is higher. So if you put the macular hole is totally and also take a long time, maybe happen for retinal detachment if you do surgery. Any question? Yeah, Dr. Cho.
To answer the question from Dr. Kung, in my experience, I never seen myopic retinal detachment after the surgery. If the retinal detached, it never detached again. Never, because I think because we already peel on the membrane, epidermal membrane and limiting membrane. So I never seen the patient detach again. But the disease can progress to one line of choroidal atrophy. Because the myopia can still progress on the myopic disease still progress.
Yeah, not very usual, but some doctors they put inside the whole or lens capsule, amniotic membrane or rich plaquettes, so it's in the hole to try to close the macular hole easier. Do you think that necessary for your patient or not?
Cho màng rau rồi tiểu cầu rồi bao thủy tinh vào trong lỗ ấy có cho không? Chỉ là một cái màng quạt ngược và lấy cái màng ăn trong chứ chưa dùng nó khác được. Từ đó ngay trong lỗ ấy có ăn luôn. Có ít tiểu cầu.
Any other question? Yes, Dr. Cho.
I never done like inverted membrane building. But in my opinion, if you do like peel the membrane wide enough, so the macular hole will glow nicely. I think that's the key. But if the macula is too big, so in the world they do like inverted limiting membrane filling. But I think it can make like a macular hole glow. But I think it's hard to improve like visual acuity.
Before I also try to put like the anterior capsula in the cataract. when I do capsulorhexis, I take it and I try to put on the macular hole when the macular hole is bigger. Also before several times I try to take the ambulocare membrane. I take from IBAN here. I try to put in the macular hole when the macular hole is bigger. But one is problem is very difficult. That when you take it, when you go and try to put it on the macular hole, is often is attached to your forehead, and as are very difficult to put directly on the macular hole. It's very difficult to put in. So that means in my idea also the show is mostly we put the invertis, internal membrane when we peeling is easier.
So I would like to ask you about the indication for using this indication with the maybe the measure the macular hole latch is have risk of the attachment, so we use it to push in the hole.
Yeah.
What indication?
For me, if the macular hole is less than 500 micrometer, we don't need for invertis.
Large hole.
Yeah, use large more than 500 micro. We can do invertis peeling. But why? Because when you use normal technique, not invertis, the doctor is very quick, but we do invertis a little bit take longer. But although just take about from 5 to 15 minutes is the maximum for do invertis macular hole.
So after surgery, this patient feel the scrotal mark.
Of course, because as you know, if the patient has often the cell, photoreceptor cell, if the photoreceptor cell is near, so the image bigger. If photoreceptor cell is discussed or larger, so patient feel the image smaller. So that means photophobia. So of course, the patient after surgery and is a patient retinal detachment or the patient high myopia often have a photophobia is normal. So you have to explain for patient. You have to accept this problem. Any other question or comment? And bravo for Dr. Next section is the year she will be talking topical international story in osteopathyloma after endoscopy PCR. Please for your presentation.
Good afternoon, ladies and gentlemen. Thank you, Professor, for some kind introduction. I am the resident ophthalmologist. It's my pleasure to be here to talk about topical intranasal steroid in ostium granulomas after endoscopic DCR. What is DCR? DCR surgery is a procedure that removes bone adjacent to the nasal lacrimal sac, incorporating the lacrimal sac with the lateral nasal mucosa in order to bypass the nasal lacrimal duct obstruction. This allows tear to drain directly into the nasal cavity from the canaliculi via a neuro-resistant pathway. There are two types of DCR surgery, which are external and endoscopic DCR. Both types have high success rate up to 90 to 95%. For endoscopic DCR surgery, there are many significant advantages, such as avoidance of scarring, minimal post-operative hematoma, shorter post-operative recovery time, orbicularis oculi muscle preservation, concurrently correct international abnormalities. On the other hand, it has many disadvantages, such as expensive equipment requiring experienced surgeon and the failure rate higher than external. So, what are the risk factors that lead to endoscopic DCR failure? There are 5 of them, which are nasal cavity size variation, osteotomy size insufficiency, ostium cicatricial closure, symmetry ostium and nasal septum or middle turbinate. Especially, ostium granulomas is the most common, taking up 38.8%, according to a study by Zhu et al. Granulomas is a type of chronic inflammation characterized by accumulation of immune cells, particularly macrophages, often with excessive fibroblast activation or foreign body reaction. The treatment of ostium granulomas involves medical and surgical management, including steroid, the mechanism of which is to reduce inflammation and limit fibroblast activation. That's why today I want to talk about regression cause of ostium granulomas under topical intranasal steroid coverage after endoscopic ganglionostomy. This article was published on Scientific Report on 24 July 2024. My presentation has 4 sections, including method, result, discussion, and conclusion. With method, the patient who has osteogranulomas after primary endoscopic DCR retrospectively reviewed between January 2011 and March 2015. All the surgeries was conducted by a single surgeon. Inclusion standard in this study, including short follow-up period of under 6 months, previous sinus surgery, radiation therapy, neoplasm in the lacrimal drainage apparatus, post-traumatic bony deformity, and surgical removal of the granulomas. For surgical method, patient was given general anesthesia, then the nasal cavity is congested by lidocaine and epinephrine. After that, the nasal mucosa is injected by lidocaine and epinephrine. Operation conducted by a 0 degree 4 mm endoscope. There are four steps, including inside and remove nasal mucosa, remove lacrimal sponsor bond inside and remove lacrimal sac wall, and finally insert binacular silicone tube. After operation, the nasal cavity is packed with gentamicin and 40 mg per milliliter of triamcinolone acetonide sulfonaceprol. All the patient was examined with 13 degree 3 mm nasal endoscope system after administering of lidocaine nasal spray post-operatively at 1 week, 1 month, 2 months, 3 months, and 6 months. Fluticasone furoate nasal spray was prescribed once daily for 4 weeks since post-operative day 1. The silicone tube was left in place and removed at around 3 months post-operatively. When osteum granulomas grew inside or displayed the inserted canaliculus intubation set tube or impending blocking of the osteum, patient was administered 0.1 millimeter of intralesional TA injection and monthly monitor after the TA injection. The osteum granulomas is classified as follows: location, shape, and number. To evaluate the outcome of this study, the first study records the time point when the granulomas developed and sequential changes of the granulomas. Secondly, the success rate of DCR were analyzed both anatomically and functionally. Finally, subcategorize the osteum granulomas into TA and non-TA group to evaluate the sequential changes and anatomical functional success rate between the two groups. And this is the sort of this study. There are 72 osteoid with granulomas in 57 patients. The anatomical and functional success rate 19.2 and 18.7% respectively. The follow-up periods was from 6 to 24 months. The